Hi, everyone. Welcome to our very first P.A.D. test breakdown with RVT Daniel Cartagena and it's Cartagena. And we have world-renowned RVT technologist, Denise Levy. She was our Lifetime Achievement Award winner through the Global P.A.D. Association this year for all of her achievements, being one of the pioneers in testing for P.A.D. and other vascular disorders. So thank you both for being here. The reason we started this particular podcast is because so many patients are now getting their test results before the doctor has a chance to review. We're not here to make a diagnosis. You don't get a diagnosis from us. We're not here to give medical advice. And we're only here to literally help you to just understand what you are seeing, understand the terminology, and to help you with some critical questions to discuss with your doctor. We're also here to ensure the standard protocols are actually followed in testing and to help you to be able to spot red flags if you are getting testing and someone may not be doing things in the way that they should be. So it'll give you the oomph to be able to speak up and say, hey, wait a minute, I'm not sure that this is right. So we have several patients that have brought their PAD test results to us to take a look at. We have Wanda, Mike, and Faye. We also have a live studio audience here who is welcome to ask questions anytime. And if you'd like to participate and have us take a look at your readings in the future, make sure to email them to info@padhelp.org. And we will make sure to include them in our future efforts. But we are going to scrub your name from it and your date of birth and your doctor's name and all that stuff. But just remember, this is for educational and informational purposes only. Do not act on any advice or information provided here in this. It is up to your doctor, your healthcare team who knows your situation best to make the diagnosis and treatment for you. Okay, with that being said, I do want to start off in general, just with Daniel and Denise, to ask you about your basic do's and don'ts, non-negotiables that patients should know when they go in for both an ABI and an ultrasound. Should we start with, who should we start with first? Who's ready to rock?
I think ladies first. Go ahead, Denise, take it away.
Okay. Well, in my lab, we did over 360 ABI TBIs a year. It's like taking a temperature. You want to know what is the flow at the foot and the toe. It's very important. So my patients had a bare calf, a bare toe, bare arm, to take the ankle to the brachial index, and that's all it is. And there are some patients that are artificially elevated because the artery in the ankle, the posterior tibial, will not collapse because of calcium. It's like trying to collapse a pipe. You simply can't collapse the walls of the artery. It remains open at 200 pressure and say the arm is 110. Well, that's non-compressible. So very important to follow that criteria. And my lab was nationally accredited in all 4 modalities, which means that we're accredited in everything we do. And the criteria for ABI, you have to look at, is the patient pre-diabetic, diabetic? Are they walking? Do they have problems walking? Do they have rest pain? So those are the things that we go through. A complete history, and do they take statins? And are they diabetic? Have they had any surgery? Do they have any stents? Do they have any bypasses? All of this information is very, very important.
So there should be an intake for the
Yes.
technologist at the beginning of the, oh, wow.
Very
That's
important.
interesting.
Yes.
Yeah. Yeah, I think
I'm
that's definitely important. The intake, patient history, they should be asking you questions.
Oh, wow.
They definitely need to be in shorts, I feel like. Yeah. Um, and the equipment, you know. Um, what do you think, Denise? They should be using a CW Doppler, yes, putting an actual
Oh,
Doppler
definitely, definitely.
onto the arteries. You know, you have several different kinds of machines where, you know, you just strap them up and it throws out a number, but you want to be exact. You know, the ABIs where the pressure should be the same from the arm to the leg. Basically, we're just seeing what this ratio is. And it should be generally hovering around one. It should be equal. As that number lowers, then, you know, that could suggest disease. Um,
Yes, actually, you bring up a really good point. So explain what the one means. Explain the indices.
so basically, you know, my blood pressure, let's say if it's 120 over, you know, 90. At the ankle, when I'm flat, and you know, the other thing, you should be flat. If they're doing an ABI, if you're standing up, no good. But yeah, so the pressure at the ankle, let's say if your arm is 120, it should be around 120, let's say like 110, uh, 100. But whatever that number is that it generates, it should be, you know, around, it shouldn't be less than zero point 0.8. Um, so it's just this ratio. It should be, you know, 120 over 120 would be one, and then that would make, you know, indicate that it was a normal ankle-brachial index. So it's just a ratio, a comparative ratio between the arm and the leg.
And what if you have over one? How do you know? I mean, we talk about false normals that you can get, and we see people, we're gonna get to it. Maybe we should get to the first case while I'm talking about it here, because you can definitely use phase as an example of what I'm wondering. Is
Sure.
here is phase ABI. She's come a long way. She's exercising. She's had a revascularization procedure in the past, but has gone a long time since her last one. And she's been using walking as medicine to build those collateral network of vessels. So, using her right ABI, what do you see here, and what can others learn from what you see?
Well, the ABI is normal. She's got a 1.2. The DP is still within normal range. It's borderline at 0.98. And the toe is definitely normal, 8.3.
Okay, so the digit
So we
is
would
your
need
toe.
waveforms with this as well. We would need to know what the waveforms are like, whether they're
You mean,
triphasic,
okay,
biphasic, monophasic. Um, and it's good to have the PVR for the whole
and
leg.
what's the PVR?
That would be the volumetric flow. It gives you a waveform, very much like a CW, but it's basically showing you the volume of flow, and you can detect where the obstruction is, at which level we do the thigh, the calf, the ankle, and the toe for the PVR.
Okay, so let's see. So the ankle, the PT is the posterior tibial. The ankle is the
Yes.
DP, that's the dorsalis pedis, that's on your foot.
Correct.
Okay.
Correct.
So everything looks normal here, within normal range,
Okay, here's her left.
and the same.
Okay.
It's the DP is borderline, but the posterior tibial is normal range, and so is the toe.
And so along with this, what you want to see is, what are the waveforms? Monophasic, biphasic, and triphasic. So that's something that patients should make sure that when they do get their ABI results, that they should ask their technologist or ask their doctor, hey, would you mind providing those as well?
Yes, and it should be indicated in the report.
Okay. So should we get to, how about Wanda? Wanda, do you want to share a little bit of your story? You went to go get an ABI test, and we've seen this a lot, Denise and Daniel, that in the past month we've had 3 patients report that their technologists did not have them take off their jeans. And one in particular, it turns out that her numbers were dramatically impacted. She went from a 1 to a 0.73, and her symptoms were actually improved with a warmer foot. And so they're going back to redo, but the director of imaging is saying, oh yeah, that's definitely, the numbers are skewed. We're going to have a redo.
Definitely.
So this is for Wanda. Wanda, you were one of
Yeah.
those. You ended up with, was this the test that you left your jeans on?
Yes, I didn't have on jeans, though. I had on dress pants and a pair of socks.
So they were pretty light.
Yeah. When I got there, all they did was an echocardiogram. I said, okay, you are also supposed to do a leg artery ultrasound. And he was like, well, let me call the doctor. So I had to go sit in the lobby for 2 hours. Okay. Then when they get back with me, in
Oh,
my opinion, he was rushed. He was a nervous wreck. The room
oh,
was packed full of patients. And after my insurance, I still owe $500 out of pocket for this crappy job. I don't know any other words.
Ugh, no. Okay, so this was an ultrasound. Did they do the ABI? Did they do the blood pressure cuffs over your pants, or
He
was it
put
just,
he tried to do the ABI and he said he couldn't do anything. He did not have the toe cuff. It was not an ABI that I've ever had. He was just using a blood pressure cuff.
well, that was,
It was
okay, so they were using a blood pressure cuff.
it
Kind
was
of
Go
like
ahead,
just
Denise.
cuffs. It was just cuffs. There was no little, like, it looks like a small pencil about this long.
A
So
Doppler.
yes, yeah. Did they use a little? Yeah, did they
No,
use a Doppler?
no.
No, it was just cuffs. Yeah, I've seen a lot of these ABI machines, where it's just cuffs, and I don't know how it figures it out, Denise. You know, I'm not too sure because you don't have, like, you don't have the pencil probe. But I
Mm-mm.
would, if you're going to a place that just uses the cuffs and they don't put gel on you and have this, it's called a continuous wave Doppler.
Mm-hmm.
Uh, I would say that may be a flag. You can flag that
Yes,
scenario for sure.
I knew it right when he was doing it. I knew because I've had a correct leg ultrasound and I've had a correct ABI. And I'm
Understood.
like, what's the deal, dude? You're not doing this right.
Yep. Yep.
Okay,
yeah,
so
I
let's,
think if it sounded like he was not prepared to do a complete study. And
No.
my philosophy is if you don't have the time to do an accurate study, reschedule it. Don't try to fit it in because you're just bad data in, bad data out.
Yes. And
Uh,
so I asked my
you can't
doctor,
rush
"Hey,
this stuff. You have to take your time and do it right.
I agree.
Or
And
don't
he
charge the
rushed through it.
patient.
He
Don't
rushed through
charge the patient.
obvious.
But
Also, when I asked my doctor, I had a telehealth conference with him, and it was 11 minutes that we spoke. 40 bucks out of my pocket, which there's no telling what my insurance company paid him. And it was only 11 minutes, and I told him how the tech did it. And he said an ABI is useless. And he
oh,
jumped straight to he wants to do, and he did this the last time I saw him. The only way for me to really tell what's going on with you is an angiogram. And my interventional cardiologist before him was the same way. No leg, they don't really want to do the leg artery sound, ultrasound, there's so much terminology, or an ABI. They want to jump straight to angiogram. They want that cash. So, I've got good insurance.
well, the
So,
You're
benefit of the
you are
ABI
astute.
pre-op is what was it when you were, your artery was blocked? And what will it be after the angiogram with intervention? It's like taking a temperature. When you're sick and you have a fever and it's 110, then you get your temperature down after you take your Tylenol or whatever. That's showing within normal range. So it's very important to get the ABI pre-op before intervention so they know how much you improved. And did
We
the
have quite a
intervention
few.
work?
I
And we have
agree.
quite a few doctors that say that they, no matter what, they will always get an ultrasound because they don't believe that the ABIs are that accurate. They get more information from an ultrasound and they can decide better on the next course of action with an ultrasound versus an ABI. Because as you were mentioning, Denise, that there are, especially when it comes to diabetics and chronic kidney disease patients, where the pipes are just rock hard below the knee, uh, you can get some false results.
Correct. But I think it's the experience of the lab. How experienced are they doing ABIs? I mean, when you look at my lab of doing over, close to 400 a year, uh, we're very skilled in this. And it seems like a simple test, but there's really little nuances that will clue you in as to looking at a prior ABI where they were normal and now they're non-compressible. You know that the disease has progressed with their calcium.
Yep.
Yes.
And a lot
I-
of times, for example, in your case, Wanda, you have your doctor, you've been with your doctor for a while. He knows your case. He's seen previous results. He knows we're just kind of biding our time and we're trying walking as medicine and some other lifestyle modifications to try and just keep you going and delay a procedure. But in your case, it seems almost inevitable, is what he's saying, that there is a procedure that is in your future. And so he doesn't want to put you through a whole bunch of unnecessary additional testing when he knows he's going to have to go in anyway and use what's called intravascular ultrasound, or IVUS, to really get the ultimate picture, 3D picture of your vessels, where they use audio waves, right? Again, to get a better 360, view of it. And they can, while they're in there, really understand the size of your vessel, and they can understand the type of plaque that they're dealing with to decide the best course of action. Some literally go to an angiogram like that, with just as a diagnostic, and they call it staging, where they don't treat you at that point, but they get these incredible images. And so then they reschedule you for a couple weeks later to come back in with a more planned out course of action that they have presented to you and you both have agreed upon. Daniel, you're nodding your head. That's on point?
Yes.
I mean, I would say, yeah, if I was a provider, I would, want to tell the patient what I was planning on doing, what the diagnostic angiogram showed, and what is our prognosis,
Mhm.
what do the plaques look like? Do I think that, that these occlusions would be hard to cross? I mean, some of these, arteries, you cannot, once they're occluded, they're going to be hard to open back up. So I think that that's kind of, that's standard of care stuff for sure.
So let's look at hers really quick and we'll get to Mike and we'll wrap up here on our first session. I don't want to take too much of your time on day one. We have more to come, more weeks to come. So,
Yes.
I see a lot of different waveforms here. And I know Denise had talked about the importance of waveforms, monophasic, biphasic, and triphasic. And I don't see any triphasic here. Do you want to just run through what each of those means, and does it matter where it is? Does it tell you, based on where that waveform is, where the potential blockage is?
Well, you also go by the velocities, and these velocities coming in at the common femoral should be over 100. So we look at that, and we look at the waveform is very important. So as the waveform flattens out and doesn't have a sharp upstroke, it tells us that what the flow is coming from the aorta and the iliac arteries. So the inflow is so important because it will let them know we do need to look at the iliac and aorta. to see what we have before we go in with an angiogram.
So this is a situation where you're looking at her distal CFA, her proximal PFA, proximal SFA. You're looking at these velocities and you're saying a really good question for her to ask now in looking at this is, hey, doctor, should we do additional imaging and ultrasound for the inflow, the aorta and
Yes.
higher, higher up?
Yes.
So that's an
Yes.
important question to ask. Okay.
Very
So
important.
the aorta and iliacs are what you would suggest that
Correct.
are looked at before to make sure what's going on. What is a normal velocity and what is considered, and that would tell us what would be considered high and low.
Well, usually it's at 100, 150. If it
Okay.
gets to be around 300, then we're looking at disease at that focal area. That's
Oh,
the one
really?
good thing about arterial is that you really do have to examine every single centimeter of that artery because you can have very short focal stenosis that could be 75 to 90%. So with arterial, it's very important to look at every every artery in 3 different levels of that main artery. Uh, so um, the waveforms are super important, especially at the common femoral.
So for hers, we're looking at her velocities and they're all pretty low, which is what you're saying. It indicates that things are happening higher up.
Correct.
And
And
Daniel's nodding his head.
anything
Yes.
that's monophasic, flat waveform, higher up, will continue the entire leg. It does not
Gotcha.
change. It doesn't go from monophasic to triphasic. It doesn't go from diseased to normal. So
Right.
the waveform will be abnormal all the way down because it is inflow. It's coming from the groin to the
Oh.
ankle.
Wanda,
Uh,
that's really helpful, isn't it?
Yeah, if I'm understanding her correctly, she's saying higher up. How high up? Do you
Correct.
mean
Higher up anatomy wise, above the groin.
above the groin?
Correct.
Into the iliacs.
Into the pelvis. Correct.
Mm-hmm.
Okay.
Mhm. Yeah.
So that would be your request for your doctor and knowing and saying, hey, I mean, you would think that the doctor would know, and he probably, I would imagine with your particular doctor, he kind of knows where to go, and he probably is like, you know what, I just know there's something going on up there, and I know your risk factors, so I'm just going to go in for an angiogram and not waste any more time.
Yeah,
That
that's
can be the case.
yes, because this is what he'll do is angiogram and go immediately to angioplasty that same
Right.
day. That's
Right.
what
And
they
and
do.
normally he would. He's
Mhm.
not the type that just does procedures simply for the sake of them. He is waiting to see when you're ready and you don't have any wounds on your foot. So um you still have time to use your walking as medicine and other lifestyle modifications. So that's good.
Yes, yes.
Okay. So let us know if you do request another ultrasound of your aorta and iliacs for more of what Denise has said is aortoiliac disease, which is the higher up. It's still a part of peripheral artery disease, but it's just higher up, right?
So I should tell him I need to request an aorta iliac sound.
Aorta iliac. Correct.
Okay.
And I would
Okay.
request another ABI pre-op that they have time to do the toe as well,
They don't even have the machine there. That tech does not even have a machine there for
that they
that.
don't. So sometimes what they do is they'll use an arm cuff. They'll do an arterial scan. They'll put the arterial duplex probe at the ankle and do the cuff. And it's not billed as an ABI because it's part of the exam. You
Okay.
need a separate machine to do an ABI, TBI, not a
Right.
duplex scanner. So some
Mm-hmm.
of these places that don't do a lot of ABIs will simply put an arm cuff on the ankle and use a duplex large probe to get a waveform and a pressure and
Mhm.
Okay.
compare it to
Wow.
the
I've
arm.
never seen that. Wow.
That a lot of labs do that now because they don't want to purchase the machine to do the ABI TBI,
Mm.
but they cannot bill it as an ABI TBI. It's part of the arterial duplex.
Interesting. So that's good to ask. And it's good for everyone to know. I mean, if you want a really good, solid, comprehensive look, you definitely need to go to an accredited lab and make sure. If your hospital doesn't have one for legs, you should, look for one. Maybe not every area, you might have to travel.